there were two abstracts that were presented at this year's ASCO, and namely, to start off with, was the updated data on the COMMANDS trial, in which we have some overall survival data. And just wanted to get your opinion on the data that was presented in terms of efficacy as well as safety.
Well, maybe I can start by just briefly summarizing for our viewers what the COMMANDS trial showed as kind of a reminder, and then we can talk a little bit more about those details of survival, which are so interesting and important. So just to remind everybody and get everyone on the same page, the COMMANDS trial is a randomized controlled trial of patients with lower risk myelodysplastic syndromes who are red cell transfusion dependent, who are randomized to either luspatercept or exogenous EPO in the kind of standard dose and schedule that we would give that. And what this trial showed is about a 60% or so red blood cell transfusion independence rate, where that was pretty stringently defined by the number of weeks you had to have without getting a red cell transfusion. In the control arm with exogenous EPO, if I remember correctly, it was slightly under a 30% rate or so of red cell transfusion independence. So basically, luspatercept was about twice as good at achieving RBCTI. And then when you look at other measures of benefit, like average hemoglobin increase, those suggest that somewhere in the range of 70–80% of patients with luspatercept get a really meaningful improvement in their red cell levels compared to around 50% or just under 50% with exogenous EPO. So clearly a winner in terms of the primary and secondary outcome measures of the trial. But what you asked about here is this new data with overall survival that came out at ASCO, which is kind of adding to that prior interest and excitement. So I'll maybe ask one of my colleagues to talk a little bit about that.
Yeah, no, when I saw the results, I was excited. A lot of people did not see this coming, right? When we treat our low-risk MDS patients, it's all about quality of life. We're trying to reduce transfusion requirements. We're trying to keep them out of the hospital, but we never think we're really modifying disease, right? I could eventually think of luspatercept as a erythroid maturation agent, but in this updated analysis at ASCO, annual ASCO meeting, the median survival was not reached compared to 46 months or so with ESAs. And if you even look at the subsets, regardless of the ring sideroblast status, transfusion burden, EPO level, you still see that trend for survival benefit. The question, yes, we have to follow up, we have to see if it does show that eventual, like the final results. But I would say the biggest question is why. I don't think it's as simple as we're reducing transfusions, that's why survival is seen. Maybe luspatercept is more than a erythroid maturation agent. Maybe it has a more complex mechanism of action. So definitely really interesting. I look forward to looking at future results, but it basically really confirms why I choose it as my frontline therapy for my low-risk MDS patients.
Yeah, and I would piggyback off of that to highlight, a lot of times in teaching fellows and working with other community oncologists, I try to address the fork in the road when it comes to managing MDS, and higher risk, lower risk, and generally your focus with the lower risk is alleviating the symptom burden and helping to address the cytopenias which contribute to that symptom burden. Now, having survival benefit, I have to adjust my discussions and adjust my talks to really highlight the importance that we see here. On top of improving the symptom burden by alleviating anemia, and on top of the benefits that we know in doing so, now you have survival benefit. And I think that gives even more credit to the use of luspatercept, especially for patients who may be kind of borderline on the transfusion dependency. I think we probably all have patients who kind of hover on that transfusion dependent line, and gives you maybe a quicker trigger to want to consider using this sooner.
Yeah, and I want to expand on something that one of my colleagues said too, about how we don't really know what's happening here. Like, we don't know the mechanism. And to unpack that a little bit more, correlation is not causation. This is an exploratory kind of an analysis. It's very exciting, but it doesn't prove that luspatercept improves survival. But it raises interesting questions. So, for example, we don't know why people died or didn't die across these study arms. Could it be that having a better average hemoglobin and not requiring transfusions or as many transfusions, maybe that reduces cardiovascular mortality? Like maybe that's what it is. Maybe it's not disease modifying. Or one thing that was raised during the session at ASCO, which I thought was a really great question, is maybe it's actually avoiding the harms of chemotherapy that is associated with improved length of life with luspatercept. And all of those things would be important. None of that changes me being excited by this finding and it continuing to reinforce that I will use luspatercept as my first-line treatment for most of these lower risk MDS patients. But it raises interesting questions about why there would be this striking difference in survival. And that's something where the answer is yet to come. But maybe we'll hear about it at conferences next year.
And I think also at the meeting, the question about progression to AML, I think that was a good point because a lot of people say, is that the reason? But the number of AML patients who actually transformed to AML was pretty much similar. I think it was around 4%. So that's likely not the reason either. So, but yeah, I totally agree that those are really possible. That's really, it's exciting. And those ideas make a lot of sense. But like you said, we have to wait for future results. We have to follow up on this.
So then I ask all of you now, based on this updated data, is luspatercept then your primary treatment in the first line setting for everyone?
Yeah, it is for me.
Yeah. Same here. Same here.
Yes.
Okay.
And I know some people do continue to prefer EPO first line in the RS negative patients or maybe in the patients with low serum EPO levels. And I'm just not sure that that's the right or best way to proceed. And the more that we learn about the benefits of luspatercept, the more I'm convinced that probably this should just replace EPO upfront for all of these low risk patients. And I worry particularly about sequencing and loss of efficacy, because if you look at the Medalist trial where luspatercept was first approved just in the RS positive patients after failure of EPO, the response rate, the response duration, it's not what we see in the frontline setting. And those are supposed to be the ones who do the best. So I think that if we don't use luspatercept up front and we use EPO instead, I'm worried that we could be compromising the efficacy of luspatercept in the second line. So, seeing now that there are perhaps survival benefits even associated with first line luspatercept instead of EPO, it's another reason to think it could actually really be the wrong thing to do to start with serum EPO. Whereas, before I might have said, well, reasonable people will disagree, we'll have different rationales for doing this. I think that it's more difficult to make the case for using any other therapy first line now, honestly.
Yeah, I agree. I think I would add to that the one area that's been intriguing for me is looking at patients with renal insufficiency. And so people with CKD, is that a group? And I have used both luspatercept and EPO. A lot of patients have come to me on EPO by their nephrologist and, subsequently diagnosed with MDS. And I think this is an area that has created some interesting conundrums. I mean, and I have actually switched a lot of them still to luspatercept. I know not always included in these trials, but have had the same great success. And a lot of times, honestly, it's, again, what I've highlighted already would be the logistical issues. But that's one area where I've wondered, is there maybe an area there with those patients with CKD? Is there maybe a little bit more benefit? I don't know. I'm just trying to think, playing devil's advocate, is there some venue where ESAs might be preferred? But still, I would say my preferred agent across the board would be luspatercept for many reasons.
And then there's this question about whether we could or should do both. And as you know, that clinical trial is going on. Some people say, well, if an ESA promotes early stage maturation and an erythroid maturation agent promotes more late stage maturation, why shouldn't we combine them together? And well, maybe it's not safe, maybe it's not tolerable, but maybe it's 1 + 1 = 4, which is often what doublet therapies do in oncology. So that's the next thing I'm most excited about actually in this space. That and the dose escalation trial, just going to the maximum dose, the Maxilis trial. That would just make this easier of a therapy to use logistically.